categorically reject it. If rationing is done now, to some extent, providing care to some and not others, how can we improve and not give up our individual freedom while doing so?
It's a great question, and there's a lot of talk about rationing. And why is it important? We have a fundamental predisposition in this country toward life. It's one of the things that our framers bequeathed to us through the founders of this country, and it's something that separates us a bit from other countries in the world. We have had to deal with this as an issue in our country for many years, and you can remember some of the cases perhaps that made the news. Karen Ann Quinlan, Baby K, recently Terry Schiavo. In all of those instances, there was a question about what became feudal care. When was it too much? And by the way, the idea, the concept of feudal care has been around since the time of Hippocrates. But what is one generation's futile effort is the next generation's bold experiment, which is the next generation's efficacious therapy. We only have to look to organ transplantation and think dialysis. These are things when they were first tried were almost science fiction, and now they're a matter of course. When the courts have gotten involved in this issue, the courts have basically come down to the side of the family. What we're concerned about now is a piece of legislation that shifts the balance of power, that takes it really away from the family working with their providers into the realm of a federal bureaucracy. So now we have to deal with the allocation of scarce resources. There's only so much medicine to go around. How are we going to do that? It's happening now, as we hear in this debate, that insurance companies will sometimes make these decisions, and we only have so many doctors and things of that nature. But one thing that we have to take heed of is the comparison that we're being shown in this bill. What we see in the United Kingdom and what we see in Canada. In the United Kingdom, they have a committee. Well, ironically, the acronym is NICE, N-I-C-E, and it's not very nice to the people of Britain. This committee establishes what's called a quality-adjusted life year. So they take you in your disease state and they say, well, how good is your life? And we'll put a dollar value on that right now. And then we add up the amount of years we think you're going to live when you get this treatment. And if the cost of the treatment is more than the sum total of your quality-adjusted life years, you don't get it. That's happening today. Well, we're faced with a bill that is now putting into writing that very same type of thing. It's called, in the House bill, the Senate bill's a little different name, the House bill is called CHORE, or the Committee for Health Outcomes and Research on Effectiveness. Rationing the allocation of scarce resources, it is happening. The market can help with that. When we have a preeminence on families and life, it's going to happen in a natural way that we're comfortable with. Doctors are already dealing with these questions. We're already handling these questions right now. The point is, do we hand it to a federal bureaucracy, or do we not do it? I'll leave it. Let me give you one more statistic, though, real quickly, as long as I have the money. I mentioned that nice cake. Well, this is for real. Okay, cancer outcomes in the United States are far superior to what we see in single-payer plans. We hear all the time attacks on the quality of our healthcare system. If you have prostate cancer and you live in the United States, your chance of living 5 years or longer is 90%. It's 57% in the United Kingdom. That's a big difference. Why? Detection. We have a lot of medical imaging devices. You can get an MRI here, you can get a CAT scan here. We can detect your cancer earlier than they can in other parts of the world. So while we have some rationing that's forced upon us when we have to allocate these scarce resources, we do have a system that is capable of dealing with that given the sensibilities of our country. Thank you.
Thank you, Ryan.
The bill calls for the appointment of a Health Choices Commission. That commissioner is answerable to nobody. The health commissioner's decisions are not reviewable but under the Administrative Review Act or under the judiciary. They're not reviewable. that means that the American people and providers, with the exception of the initial setting of the Medicare rates under the single-payer system, have absolutely no influence upon the person who makes these decisions. That person also decides what coverage, and the extent of the coverages, the copay, the deductible, in every private plan that's offered, and in the health, and in the option plan, the public option, because all those insurance plans must have exactly the same benefits. So if one person can tell us Americans, the nature and the extent of the coverages, that's rational. The second point is, and I've just got to read this, I know I'm going over my time, but let me read you section 1173 of the National ID Health Card. It says, the goals for finance and administrative transactions are such standards shall enable the real-time determination of an individual's financial responsibility. Real-time means that you can read something. It's readable. And the person goes in there with a card or a bracelet or whatever. At the point of service, and to the extent possible prior to service, including whether the individual is eligible for a specific service with a specific physician at a specific facility, which may include utilization of a machine readable